Assalamu alaikum. Today's topic of discussion is another topic, very important topic of rheumatology, that is rheumatoid arthritis. So again, we will take it as a topic, along with we'll discuss its history. How do we can take a history of joint pains and how to take it as rheumatoid arthritis. So rheumatoid arthritis, it's a chronic systemic inflammatory disorder which is characterized by synovitis of the multiple joints. Its prevalence in 1% of the population, this is American figures, and more common in females, thrice as common as compared to males, present in the 4th to 5th decade of life in females and 6th to 8th decade in men. And mostly it's if a patient is having family history, so it's more prone to have RA. Plus if we go for genetic studies and allele study, then we can get HLA-DR-B1 allele. That is more significance for, and the patient is prone to RA. Then we will discuss its clinical features. Mostly common involvement are the joints, in which multiple joints are involved, including it may have redness, swelling, tenderness. There can be morning stiffness, which would be more than 30 to 60 minutes. And mostly in RA, proximal interphalangeal, metacarpophalangeal joints of hands are involved, and distal interphalangeal, they are spared. Along with hands, there can be involvement of knees, ankle, and foot joints, metatarsophalangeal joints. There can be certain patients in which no involvement of joints. There's only tenosynovitis. There can be bursitis, not exactly involvement of two joints. There can be involvement of atlantoaxial joint. Then there can be rheumatoid nodules, which can be found in the lungs, sclera, tendon sheaths, and in bony prominences. Then ocular symptoms are very common, which includes dryness of eyes, episcleritis, scleritis leading to scleromalacia, and ulcerative keratitis. If there is organomegaly, that is splenomegaly or neutropenia, then it can be Felty syndrome. There is involvement of lungs as well as cardiac involvement. Skin, as I already mentioned, rheumatoid nodules, and there can also be leukocytoclastic vasculitis with this. Nervous system can also be involved if there is some entrapment of nerve like median nerve, leading to carpal tunnel syndrome symptoms, and there can be mononeuritis multiplex, and there can be signs of cord contraction if atlantoaxial joint is involved. Along with these systemic in clinical feature, there can be fever, weight loss, lymphadenopathy. There can be osteoclastic activity of bone leading to osteoporosis due to the drugs, due to the disease itself also. So here comes the history. We will take it as joint pains. If a patient comes to you with joint pains, so how we are going to take history of presenting illness. And first of all, we are going to start it as OD para, that is onset, duration, intensity, progression, aggravating and relieving factor, and the associated symptoms. I will narrate an example, so it will cover all the OD para in the first paragraph. Like my patient, normoglycemic, normotensive, presented with a complaint of joint pains for last 1 month, which was gradual in onset, 1 month in duration, progressive, continuous, initially symmetrically involving the small joints of both hands, followed by involvement of knee joint without improvement of the initially involved joint. Pain was mild to moderate with a score of 6/10 associated with restricted movement, as patient is unable to perform fine works like embroidery. Pain was temporarily relieved by oral painkillers, and it was associated with half-hour morning stiffness, which relieved with activity. However, she denied any redness or swelling of the joint or any deformity of the joint. This was also associated with undocumented low-grade fever. So this was all the OD para. Then in the next paragraph of the HOPI, you are going to cover all the DDs, which will include SLE. You will going to ask, there is no history of any oral ulcer, skin rash, hair loss. If she is female, multiple first trimester abortions, any tightening of skin, dryness of eyes, mouth, and difficulty in swallowing, any skin rash over the extensor surface of the body, difficulty in standing from sitting position or combing her hairs, low back pain with morning stiffness, any persistent diarrhea, nail pitting, rash with silvery scales on the body, any genital ulcers or burning micturition, and any use of blood thinning agent, any history of increased joint pains with heavy or high protein intake, any palpable skin rash, any decrease in weight loss and lumps and bumps in the body, any dry cough and tender nodes over the shin which heals on its own, any previous chronic hepatitis B and C infections or unscreened blood transfusion, high risk sexual behavior, darkening of skin complexion, and previous any history of diabetes. So these we have rule out all the differential diagnosis in our second paragraph. Then the third paragraph is of care, in which you are going to start with the etiology, risk factor. As RA is mostly familial and genetic, so if there's a family history, you have to explain it, and if there is no, you only mention that there is no family history, and then you continue with the complications. So systemic review or care, we are going to cover it from up to down, from starting from the CNS. There is no altered state of consciousness, neck pain, fits, numbness of hands and feet, any shortness of breath, palpitation, chest pain, dry cough, blood in sputum, blood in vomitus, dark black tarry stools, any yellowish discoloration or sclera, any decreased urine output, heat or cold intolerance, paleness of complexion, and in association you have to cover other autoimmune diseases. There is no history of any darkening of skin complexion, increased urination, increased thirst, white lesions on the skin. So after this, the last paragraph will be after admission, how many what investigation and treatments the patient has undergone through. So after HOPI, the same you have to ask past medical, past surgical, family, vaccination history. If she is a female, you have to ask for gynecological history, future pregnancy, any contraception history, because that's important, because we are going to start methotrexate as treatment for if patient is having rheumatoid arthritis. Then functional status is very important. If you have mentioned even in the HOPI, you have to go with the functional status again in the history as a separate entity, because it's important whether she is able to do her self-care, whether she is able to do her household, and if it is affecting her occupational outcome. And then comes the socioeconomic history. Okay, then it comes the examination, in which for rheumatoid arthritis, GPE along with joint examination of the